Yeah, thanks, Anirudh. First of all, thank you, Dr. Undi and Dr. Manoj, for this kind invitation to be at RIC at the 5th edition. Now, we have been having very wonderful sessions since morning where we are discussing amazing imaging. And we have seeing beautiful OCTA scans with Sumit discussed nicely those medusa head, dead tree appearances. But let us go back to a very basic topic, how to obtain those nice images so that we can stand on this forum and discuss them. So as we know, over the past 5 to 7 years, OCT has gained priority over the dye-based angiographic test. And that is because it helps in beautifully illustrating a lot of those networks and other things in the macular area. But at the same time, getting a proper OCTA is challenging, and it is associated with a lot of artifacts. So this was one very interesting paper that was published in JAMA that analyzed around 450 OCTA images, and it showed that the prevalence of artifacts was as high as 90%. So the motion artifact was 93%, followed by the defocus and the shadow. And not just these, there are other plethora of artifacts that are seen on OCTA images that limits our ability to actually interpret all these angiographic testing. So I will just discuss few pearls and tips to get these correct imaging done. So it starts with a proper patient preparation. So educating the patient forms the crux of getting a good OCTA imaging. So the entire procedure has to be explained to the patient, and the need of keeping the eye stable and avoiding any kind of head movement is very critical. And the patients can be encouraged to ask any questions if they have any doubts or concerns. It's very important to check the past medical history, whether the patient has undergone any kinds of ocular surgeries that may impact our proper visualization of the retina by the machine, as well as if the patient is having any ocular surface disorders like dry eyes, in which case there would be a lot of blink artifacts. A proper pupillary dilatation of at least 5 to 6 millimeters is necessary to get a proper OCTA scan. And additionally, intake of caffeine in the form of coffee or tea has been shown to impact the blood flow. So ideally, we should instruct the patient, if not at the first visit, at the subsequent visits, to avoid any kind of caffeine intake for at least 2 to 4 hours prior to getting the scanning test done. Now, after this, getting a proper imaging is important, and for that, the patient has to be positioned very comfortably on the seating chair with a proper head and chin alignment and proper alignment with the OCTA device as well. And the protocol that we select, whether if you're looking at a central macular condition like a MACTEL or a DME, we can select a 3x3 or a 6x6 mm scans. Whereas at the same time, if you're looking at RVOs, a 9x9 scan pattern can be selected. And the scanning speed also has to be selected based on the age of the patient. If it's a very elderly patient, a shorter scan speed would be better to get a proper imaging done. So once we start acquiring the images, a proper focusing is necessary to ensure a sharp and clear images and make sure the imaging beam is focused onto the desired area of the interest. And at the same time, continuous monitoring of the patient in real time is necessary to look for any kinds of motion artifacts that are happening. So we need to adjust the patient's position or the image settings as necessary to improve the quality of the images. Once the image is obtained, we need to pay attention to few metrics, including the signal strength and the signal to noise ratio, which can give us the indication of the reliability of these scans. And if necessary, the scans may also need to be repeated. Now we look at specific image artifacts. So for motion artifacts, to avoid these, most of the points have been discussed. That is a patient preparation and alignment, and a proper fixation target has to be given to the patient. And most of our machines today have eye tracking technology, so that helps to minimize these artifacts, and constant monitoring is necessary. To avoid blink artifacts, the patient has to be educated previously, and the use of lubricant drops also helps in these patients. If there are any media opacity, like a central cataract, if it is present, then the patient's head can be tilted or the position can be adjusted so that the better central macular scan can be obtained. Now, for projection artifacts, most of our current OCTAs, they come with a projection artifact removal tool, and that can be utilized. And at the same time, post-imaging also correlating with the structural on-fast and B-scan with the overflow mode is very important for the accurate interpretation. To avoiding segmentation artifacts, a slab selection in which we drag the preset boundaries along the z-axis is very necessary because it can help us generate a smaller or a larger slabs to better assess the pathology. Manual segmentation in which we retrace the entire mislabeled retinal layers has to be done amongst all the B scans. So it is rarely done in real world and mostly it is restricted to only research papers. And after the scanning is done, the machine also needs to be regularly calibrated to make sure that there are no errors, and the software also needs to be updated regularly. And last but not the least, as they say, it is not the machine, but it is the man behind the machine. So the operator has to be adequately trained to acquire the best quality images, and they should be familiar with the hardware as well as the software of the machine, and continuous education of the operators is also needed. So just to summarize my talk, to ensure the right imaging in OCTA, it involves many key steps that focuses on patient preparation, image acquisition, and quality control. And by following these steps and being attentive during the image acquisition, we can help ensure an optimal OCTA image is obtained, which is crucial for the accurate interpretation and analysis of these features. Thank you for your kind attention.
Thank you, Jay. I actually don't do so many things that you just said. And some of my patients, they get Arabic coffee as soon as they come to the hospital.
Okay.
So no coffee. So any comment? Yes, please.
Yeah. Thank you for this nice presentation. I would just state that it is really important to know the visual acuity and the fixation of the patient before performing the exam,
Correct.
and also where the lesion is located. Because if you have the extrafoveal, for example, lesion, and you would like to do the small scan, so with a high definition, then you need to center that lesion. Otherwise, you can miss it. So I think that's something important for the operator to know before.
Exactly.
Okay.
I think it's very important to write down in our notes whenever we are sending a scan exactly what is the area of focus, what we need for the scan, and so on. The operator can take the scans accordingly.
So Jay, very nice summary of some of the logistics of doing the testing. One of the things we don't often talk about in meetings like this is practice efficiency. And one of the reasons we like to do OCTA is it's so fast and so easy compared to fluorescein. So when in my practice, the OCTs get done before the patients see me. And what I struggle to do, and I'm continually trying to do, is educate my techs of when I truly want an OCTA so that I don't have to see the patient back a second time. And I think getting protocols like that set up in your practice can help you immensely get through your day in a very efficient manner.
Yes, so in that term, so like, do you mention it in your EMR, so what scans need to be taken the next time around, or any specific notes for that?
Yes, always do.
Okay.
And you do both 6 by 6, 3 by 3, or 12 by 12? What is your protocol?
6 by 6.
For all AMD eyes?
Yes.
I think one of the things that you talked about was projection artifact removal. I think it works very well, except when you're quantifying it for research. I think it takes out some information. So if you're quantifying, you have to be careful when you're doing projection artifact removal.
Can I add a comment?
Now, as far as segmentation, I think one of the advances in these softwares is that it has reduced to a great extent the requirement for manual segmentation. I think if you start doing manual segmentation, it's time for you to almost retire because you'll never be able to finish one image. So I think segmentation, but one thing that you could do is try to do whatever you can when the patient is with you in front of the machine. Retrospectively, it could become very difficult for you because you cannot correct everything and you might have to take a new scan actually.
Just a couple of
Yes,
points. Always keep lubricant handy because when the patient tries to keep the eye open, especially if you're trying a 12 by 12 scan, they tend to get tired, the eye gets dry. So always keep some artificial tears there which can be put. If the patient has poor vision, don't ask for a wide scan, especially if you're trying to get more, because you're not going to get a good picture anyway.
Right.
And if you're doing lesions like diabetes and CSCR, ask for scans also centered on the optic disc because so that you can pick up things that are needed.
And I think having an order of imaging is also helpful because sometimes if you start the patient with autofluorescence and he's exposed to bright light, might be very tired or photophobic by the time you're doing your OCT angio. So I think having a certain order or protocol in your clinic can be helpful as well.
True. And I think, Anirudh, you brought out a very important point regarding the segmentation errors also, because many times we see the scans are uploaded by the technician. So we need to look carefully at, at what section have they taken the scan. And it's very important to maybe, spend half an hour after our clinics to actually see any interesting cases where we can ourselves go and do a slab selection, because many of these newer findings can, since we have a lot of knowledge in this field, so we would be able to find out these minor lesions better than even our technicians. But we need to sit with our machine. That's
that
most important.
half an hour is the most difficult
True.
part to get. Yes.
Yeah, just small point to add. Just keep your flow on so that on the B scan you are able to correlate your NFAS with your flow on the B scan. I often see those flow being switched off, and that causes issues to interpret those.
Yeah, I think flow is really important to analyze together. Say you have a comment?
No, I just that, see your positioning of your, the OCTA machine. A lot of times you have the AC vent which comes right into the patient's eye. And that's when they need to keep their eye open and they tend to blink. So I think that's one thing also you need to pay an attention to. It's very common because the person who keeps the machine doesn't know that this has to be done like this.
Ergonomics of the machine have to be. Okay, thank you so much,
Thanks,
Dr. Jay.
everyone.
With this, I think we are looking forward.